Hi everyone, well here we are again for another video. In this video I am going to be talking about winged scapula, otherwise known as scapula alata. Now this is something that actually quite a few people have but may not realise it, and it's something that certainly you guys as therapists hopefully it will just give you a bit more information to kind of pick up on this, you know, rather than thinking, as it's easy to do, you know, when you're working on the shoulders, just thinking, oh yeah, I can, you know, I can get under that shoulder blade, and thinking everything's fine. So when winged scapula is present, basically the muscles around the scapula become weak or paralysed, which causes destabilization. This results in the medial border of the scapula protruding like a wing, rather than resting flat against the back of the chest wall. Now it's often asymptomatic, so as I say, a lot of people don't even realise they have it, but it may present as abnormal scapular movements with pain, weakness or cosmetic deformity. Now, a winged scapula can be caused by musculoskeletal or neurological issues. So, if we start by looking at the anatomy of the shoulder. Now, the scapula is the largest bone of the shoulder and serves as an attachment point for numerous muscles which stabilise and move the arm. Now, these muscles all work together, and any dysfunction will cause a rhythmic motion of the scapula. So what causes winged scapula? Okay, so it can be due to traumatic injuries. Now, traumatic injuries will be divided into two types. So we have our acute trauma, which for example could be sudden traction on the arm during maybe a car accident, or any blunt trauma to the nerves supplying the neck, shoulder and upper back, such as a shoulder dislocation, which of course is common in those high impact sports such as, you know, rugby for example. The other type of traumatic injury is where you get repetitive microtraumas. Now, so this is where you have repeated stretching of the neck, maybe due to wearing a heavy backpack for work every day, or using your arms to prop your head up while lying down. Then we have our non-traumatic injuries, which can be a cause. So here we could be looking at many different things. We could be looking at viruses such as influenza, polio, tonsillitis, any allergic reactions to medication, drug overdose, exposure to toxins, for example herbicides, injections, you know, there could have been some sort of injury at birth, post-surgical complications, for example a chest tube placement, also idiopathic you know, sort of causes such as congenital heart defects, cervical radiculotherapy, muscular dystrophy, Parsonage-Turner syndrome. We're going to go on to talk about a couple of those in this video. Also surgical causes, you know, some surgeries may cause nerve damage, for example rib resections, mastectomies. About 8% of axillary dissections demonstrate scapular winging 15 days post-surgery, but also any procedures that require general anaesthesia. Now, a winged scapula is usually caused by nerve damage on one of the three following nerves, which control the arm, the back and the neck muscles. So we have the long thoracic nerve, which controls the serratus anterior muscle down by the ribs. The dorsal scapular nerve, which controls the rhomboid muscles on the sort of mid-upper back. And the spinal accessory nerve, which controls the trapezius muscle, which again is the superficial muscle spanning across the top of those shoulders and into the mid-back. Now, this nerve damage can be a result of injury or surgery, but muscular dysfunction can also be the cause. So let's take a look at muscular dysfunction versus nerve dysfunction. So with muscular dysfunction, the following muscles may be involved. So we've got the trapezius, the serratus anterior, the rhomboids, and the levator scapulae, which is that one that runs up into the neck. Also, the pectoralis minor and the latissimus dorsi may be affected. If we're looking at nerve dysfunction, as we've said, the accessory nerve, the long thoracic nerve, and also the brachial plexus may be involved. Damage to these structures may lead to loss of serratus anterior muscle function. The serratus anterior muscle attaches to the medial anterior aspect of the scapula, which anchors it to the rib cage. So even if it's due to a nerve dysfunction, this can then have a knock-on effect, obviously, on the muscles that are controlled by that nerve. Now, true winging is not common, and it's usually a result of traumatic injury or inflammation of the long thoracic nerve, which is the one that runs from the neck to the serratus anterior muscle. The position of this nerve also makes it more vulnerable to injury. A winged scapula due to long thoracic nerve injury can be identified by asking the client to push against a wall from about 2 foot away with palms flat at waist level. Now, this nerve can be decompressed at the scalene muscles in the neck. But also, there may be loss of trapezius muscle function with damage to this nerve. Now, the trapezius lifts and rotates the scapula, helping you to shrug your shoulders. Isolated loss of trapezius function is rare, sometimes resulting from maybe radical neck surgery on tumours where the accessory nerve may be damaged. The shoulder will be depressed and the scapula translated laterally with the inferior angle rotated laterally. Now, when there is trapezius weakness due to accessory nerve damage, the client will be unable to lift the arm off the couch in supine position, or they will have difficulty with overhead activities. Surgical reconstruction or nerve release may be possible treatments. Now, also we should look at weakness of the Scapular Stabilizers. So, fascioscapulohumeral dystrophy, or FSHD, is a form of muscular dystrophy and is the main cause of weakness in the stabilizing muscles, i.e. the serratus anterior, the trapezius, the rhomboids, and the latissimus dorsi. Now, other noticeable characteristics of this will be the scapula rising into the trapezius, hypertrophied deltoids, profound winging of the medial border of the scapula, and there may also be some facial weakness. Now, what we also should look at is loss of the scapular sensory mechanism. Now, the clavicle and scapula are connected by the coracoclavicular ligaments. The scapula is connected to the rest of the body by the acromioclavicular joint. So, a lateral clavicular fracture, a ruptured coracoclavicular ligament, an acromioclavicular dislocation, or a scapulothoracic dissociation will all destabilize the shoulder joint, causing scapular winging with overhead movement. So if a client has had any of these things, that should give you an indicator of, movements that you want to assess and where you want to, work. Now, we're also going to look at secondary winging due to instability. So scapular winging and dysrhythmia commonly result from instability caused by recurrent shoulder dislocations. This leads to muscle dysfunction, which is worse with more frequent and less traumatic dislocations. So again, maybe if you're someone who's in a high contact sport, and you're prone to kind of slight dislocations, again, this might be something to consider. Secondary winging also due to pain. Now, painful shoulder conditions and reduced range of motion in the glenohumeral joint cause us to compensate with abnormal movements of the entire shoulder complex, which again may lead to secondary winging. Also, brachial plexus injury. Now, the stabilizing muscles of the shoulder are mostly controlled by the brachial plexus, which is a bundle of nerves running from the neck to the arm. Now, conditions such as brachial neuritis, otherwise known as Parsonage-Turner syndrome, can lead to weakness of the scapular muscles due to the nerves being inflamed. Now, symptoms of this will include a severe pain, which often disturbs sleep. Usually, this is in winged scapula caused by nerve trauma. There may be no pain if caused by muscular trauma. You will more than likely notice a shoulder blade that sticks out. It can make sitting and wearing a backpack quite uncomfortable. There may be weakened neck, shoulder and arm muscles due to nerve trauma. There may be difficulty in raising the arm above the shoulder. There may be discomfort in the neck, shoulders and back, fatigue, and quite often you'll find that there'll be one shoulder that will sort of droop down. Now, another symptom may be cervicogenic headaches, which originate in the upper cervical spine. This usually then will refer pain into the head. Now, there may also be referred pain from the upper trapezius or trigger points in that sternocleidomastoid muscle. So we're now going to look at types of muscular scapular deviation. So in type 1 muscular scapular deviation, we will see a visible inferior angle of the scapula, a pronounced anterior tilt of the scapula, sometimes with shortening of the pectoralis minor muscle and shortening of the posterior joint capsule. There may also be a muscular imbalance of the lower ascending section of the trapezius and the serratus anterior muscle. In type 2, scapular deviation, there will be a visible margo medialis, internal rotation of the scapula with shortening of the posterior joint capsule and shortening of the latissimus dorsi muscle, and quite often muscular imbalance of the trapezius and the serratus anterior. Then we have type 3 scapular deviation, which is where there's a visible inferior angle, downward rotation of the scapula, shortening of that levator scapulae, and a muscle imbalance of the upper and lower trapezius. Now, if we look at types of neurological scapular deviation, so type 1, we have a separated scapula from the thorax, an elevated scapula. The margo medialis is nearer the spinal line, and there may be damage of the long thoracic nerve and dysfunction of the serratus anterior muscle. In a type 2 neurological deviation, we'll see a separated scapula from the thorax, a lowering of the scapula, damage to the accessory nerve, and dysfunction of the upper trapezius. So, how do we prevent scapular winging? Well, scapular winging may not be preventable in every case, but the risk can certainly be reduced by avoiding repetitive shoulder and arm movements, maintaining correct posture, using an ergonomic chair or pillow, using shoulder-friendly ergonomic backpacks, and avoid carrying excess weight on your shoulders. Also stretching and strengthening the muscles of the neck, the shoulders and the arm, and this is where regular massage can be really beneficial. In terms of treatment may be surgical or non-surgical depending on the cause, but medical management may be more appropriate in older people who have, more of a sedentary lifestyle or minimal symptoms. Now, in terms of surgical options, surgery is more likely when non-surgical methods have not worked, in cases of traumatic injury or where there has been spinal accessory nerve damage. Now, the surgery will usually involve either a split pectoralis major transfer, which is where part of the muscle or sometimes nerve is relocated to the back or shoulder, or a modified Eden-Lange procedure, which Eden-Lange involves lateral transfer of the levator scapulae, rhomboid major and rhomboid minor, to reproduce the functions of the trapezius and support the scapula in cases of nerve paralysis. Now, the modified procedure transfers the rhomboid minor insertion to the supraspinatus fossa, compensating for the mid-trapezius and stabilizing the superior angle of the scapula. Another surgical option is a scapulopexy or static stabilization. This is where the scapula is attached to a rib or a vertebra. This may result in bone fractures, lung problems, and inability to lift the arm. So this really is very rare and, a real last resort treatment. But let's look at the non-surgical treatment options that should be tried before surgery is even considered. So, scapular winging due to serratus anterior damage may heal within 2 years without any treatment. But 2 years is a long time, so you can also try anti-inflammatories, muscle relaxants, analgesics, physiotherapy, using a brace for several months in the early recovery period, massage for dorsal scapular nerve damage, and home exercises. And in terms of recovery can take several months to years, but certainly early treatment will improve the outcome depending on the severity of the damage, whether the person undergoes surgery, and which nerves or muscles are damaged. So there are exercises that can be done. Stretching exercises may help strengthen and improve range of motion, but sometimes can make the problem worse. So it's well worth, consulting with either a physio or a sports therapist, to see which exercises would best suit you. Because obviously you don't want to kind of worsen the issue. So possible exercises that they may recommend are scapular retraction, where you pull the shoulder blades back while in standing position, holding for 10 seconds, then you'll rest for 10 seconds and repeat 10 times. Another good exercise is external rotation, which can be done with a resistance band or just with a light dumbbell. Or, if you don't have dumbbells or a resistance band, even just a bag of sugar. You can attach an exercise band to a closed door, holding it with a hand crossed over the body, elbow at 90 degrees, and then you pull the band in front of the body and to the sides. So pulling outwards, that would be external rotation. Not moving the elbow, keeping that elbow tucked in, and you'd repeat that 12 to 15 times. But alternatively, you can do this exercise with a dumbbell or a bag of sugar, in a side lying position. Again, just pulling that arm down towards the floor. Now, another exercise that certainly your sports therapists may recommend is standard push-ups. The back should be flat, the legs outstretched, and the hands should be flat against the floor, farther apart than the width of the shoulders. Bend the elbows and lower the body to the floor, then push the body up, resuming the starting position. Now, you don't have to go all the way down, you can just go part way down at first if that's easier. Slowly increase reps up to 12 to 15. You can also sort of adjust this exercise by doing a plank and then basically tapping the opposite shoulder for sort of a couple of seconds and then down, and sort of alternating. So that's your overview of scapular winging. So if you've been for a massage, maybe you've been told that you have this, hopefully this has given you a little bit more information of what causes it. And if you're a therapist, hopefully this has given you an idea of which nerves and muscles you need to be looking at and who out of your clients could be at risk of this. But do feel free to, if you've got any questions, you can contact me through my Facebook or Instagram. I'm on there as the Medical Massage Lady. Feel free to comment down below. Do subscribe to my channel. There's lots more videos on various sports injuries, muscle dysfunctions, medical conditions, so do take a look. Yeah, if you're a therapist and you would like to do some training in issues such as this, do take a look at my website, www.medicalmassagelady.com. Yeah, that's really it from me. So I'm sure I will be back again soon with another video, but for now that's all on winged scapula. So I will see you next time.